We're joined today by Dr. John Kitchens. In terms of geographic atrophy management, it's kind of shifted from watch and wait to more early intervention. Where is that shift headed next, do you think?
Yeah, so I think it's going to continue to focus on identifying patients with geographic atrophy and trying to find the patients that will benefit the most from GA therapy. And even though we've only had therapies for GA for about 3 years, it's been a pretty rapid evolution. We've gone from 5 years ago thinking GA was a slowly progressive condition to actually now looking for GA, identifying GA, realizing that it actually progresses much faster than we had anticipated, and then trying to find the ideal patients to treat. And that last part, that finding the ideal patients to treat, has really been kind of the linchpin. I can tell you that I treat a different cohort of patients now than I treated when the GA drugs first launched. I think the key is to appreciate the patients that have the most vision to preserve. We obviously want to offer treatment for patients that might even have some foveal involving GA, but still useful vision. But now it's about finding those patients that still have very good vision, that have the early GA that you can pick up on. And maybe those patients aren't interested in treatment right away, but if you can follow them over 4 or 6 months and identify that they're progressing, it's not hard to convince a patient when they see progression in their eyes to know that they have a problem. And listen, with GA, when it's gone, and it's gone, and you can't get it back. And so that's why preserving those patients with as much RPE as possible is so critical. So I think it's that continued evolution, education around our referring doctors who are doing a remarkable job at identifying GA. I'm so impressed with how many optometrists can recognize GA now, even subtle GA. They know how to look for it on OCT and autofluorescence, and they're referring the patients earlier and earlier. And so I think it's just that culmination of finding everybody that has GA, finding the patients that have the most to lose and treating those patients, finding the patients that have the earliest signs of progression with as much valuable RP as possible, and talking to those patients about treating them and trying to give them the most runway for continued vision.
What might that communication look then for patients who are, helping them understand when GA treatment is appropriate for them and when it's not?
I undersell GA treatment to all of my patients. I feel like I am actually kind of anti-selling the treatment, because I tell the patients, listen, you're never going to see any better than you do right now. This only slows it down by about 30%. You have to get shots every month or every other month, consistently. And it's not going to restore any vision or make you see any better. And what's really remarkable is after I've taken time to show that patient their atrophy and how it's progressing, or the patient realizes that they're noticing a visual scotoma or a problem secondary to GA, 80 to 90% of patients say, sign me up. And I kind of sometimes I'm taken aback and I say, really, what is it that I said that made you want to get this treatment? Because I'm curious to know, because I feel like I'm not a very good GA treatment salesperson. And they say, what other choice do I have? I mean, I can see that I'm losing, potentially going to lose vision if it continues on its same course, and I'll do anything to continue to see. It's a bilateral disease in many cases. And once again, when it's gone, it's gone. So I think the key to patients really understanding that they need treatment and wanting treatment is they have to know they have a problem. And they're going to know they have a problem in two ways. They either are having visual symptoms, they're noticing a scotoma, they're noticing, progressive vision loss. And in that case, sadly, sometimes you're almost behind the eight ball. Or you show them that they have a progressive problem. And you can do that very nicely with advanced RP analysis. We use Zeiss OCT, has a great algorithm where you can actually show the patient what their RP looked like at any point in the past, and then where it is now. And you can say, here's your foveal center. They put a little red dot on the reference image that shows the foveal center. And you can say, here you were a year ago, and now here's your GA now. And look at how much closer it is to your center vision. And I find by using those visual aids, using the patient's own eyes to educate them, we have a lot better uptake for patients wanting to receive treatment.
And, we've made a lot of advancements in The treatment of geographic atrophy in recent years? I guess what do you feel is still the unmet need, or where is the niche, or what is the greatest need yet to fill?
Yeah, I think identifying patients earlier, we're doing a better job with that, especially once again, our optometric and general ophthalmology colleagues are doing a remarkably good job of identifying GA. I think we need better treatments. I mean, it's great that we have some advancement in the field, that we actually have a treatment now. I have friends in Europe that don't have access to GA treatments, and they're extremely jealous that they don't have something they can offer to these patients. But we got to do better than 30% reduction of RPE progression. We have to have therapies that show a visual benefit to our patients. Once again, I think we're further away from having treatments that actually can improve the patient's vision. I think that is on the horizon, the distant horizon, but I think we have to do better than 30% and no visual acuity differences between, the control groups, which is what we saw in Gather 1 and Gather 2 and Derby and Oaks.
Is there anything to add that I haven't asked you, or you feel is really important for the audience to know?
Yeah, I think the things to look forward to in the next couple of years would be there's a C1q inhibitor and from Annexon, and my initial impression was, oh, this is just another complement drug, and it's going to work the same as the drugs we've seen, Izervay and Syfovre. Truth is, it's very different in its mechanism of action. C1q targets photoreceptors. It targets the synapses of the photoreceptors and causes photoreceptor cell death, which we think precedes, or beginning to understand more and more, precedes RPE loss and RPE death. And so this might be a different therapy that actually does allow us to see a delta in visual acuity differences. Might not show RPE loss differences, but the thought is if you can save the retina, you likely are going to have a better chance at preserving the RPE. More distant, but actually interestingly, kind of knocking on the doorstep, about to go straight from phase 1 studies to phase 3, are some cell-based therapies, and the one that's leading the way there is Astellas. We initially know Astellas as the company that acquired Izervay. And my initial thought was, oh, they want to get into the GA space because they see it as a good growth market as far as that goes. But the truth is, and my words, not theirs, but the truth is that they've had cell-based therapies they've been working on for 10 years. And I think they probably looked at Izervay as an entry into a market where they will have better treatment options. But they wanted to get, boots on the ground, get an idea of the space, get an expertise in the area before they actually moved into what could be restorative therapy, which is cell-based therapy. So really talking about stem cells and whatnot. They released their phase 1 data at ARVO this past year, and basically showed that they had significant number of patients that gained 2 lines of vision. Small numbers, early study, but it was promising enough that they're going to go straight to a phase 3 study, which would be amazing to have something that actually could be restorative for patients who have vision loss from GA.